sober, busy living sober, busy living sober. I am so excited, and I say this all the time when I've guests on, but this guest I'm really excited for because Dr. Kamerlink is the one that has literally helped me with my back. And I have to tell you all a little story. So I went into his office because of my herniated disc in my back, which was a thoracic area, correct? And that's like in the middle of my back.
Yes.
And a lot
Yeah.
of people don't get herniated disc there. But I of course I'm a weirdo, so I had one there. And I went into Dr. Camerlink's office. And first off, the one thing that I noticed was like they were like, "Can I have a urine sample?" And I was like, sure. Okay, why? I've been sober for almost at that point, almost 18 years. Now I'm over 18 years. And I definitely am not pregnant because I'm almost 56 years old. And I was so dumbfounded by it. And but I went in, and when I met Dr. Camerlink, he just has a great bedside manner. He's totally, I mean, it took me a little bit to get him to be like, come on, talk to me. And he finally started to talk to me. And I said, tell me what it's like. And with medicine today, and I said, and having to test people that they're on medication or not and what they're taking before they come into your office. And I love that you do that now instead of being like, oh my gosh, why are you testing my urine? You don't, you know who I am? It was more like, oh, wow, you're being really responsible, aren't you?
Yeah. So, I mean, it's commonplace everywhere in this country now to test for illegal substances. And then on the flip side, when we do have patients that are on chronic opioids, we're testing to make sure that they're actually taking it because there has been a problem with diversion of these drugs. With the opioid crisis now, the economics and the legality of opioids has dramatically changed things. Anybody can turn on the news probably at least once a week there is some segment on the nightly news about the opioid crisis. It has been a huge problem stemming from the late 80s to present day. I would say probably in the last maybe 6 or 7 years, it's really become front and central. This started way before COVID. This was not a COVID related type of thing. But now, with the rise of street drugs, because of having it more difficult to obtain opioid medications, you're seeing a lot of the street drugs now laced with fentanyl. And what people fail to realize is that fentanyl is an extremely potent opioid medicine. It doesn't sound like an opioid. It doesn't sound like your typical hydrocodone or oxycodone or oxycontin or Vicodin or tramadol, but it is an opioid medication, and it's about 100 times stronger than morphine. And you could easily turn fentanyl into basically a powdery substance, sprinkle it over any type of illegal drug, and not even know that it's there. I mean, you've heard multiple reports of people buying street marijuana, smoking it, stopped breathing, and then died of fentanyl overdose. You see it laced in cocaine or heroin or countless drugs, and the synergistic effect of the illegal drug as it is plus fentanyl on top of it. I mean, it's basically causing people to overdose, and it's becoming a huge problem. Um, in our practice, we're commonly looking for street drugs because it poses a very high risk type of pattern, regardless of whether we're doing an injection for somebody or we're prescribing any type of substance.
All right, I want to go back to the beginning now of your journey into medicine and why did you want to become a doctor? And he grew up in Chicago. Tell us what that was like. Why did you want to be a
Uh,
doctor?
so I remember very vividly, I was a freshman in high school. I was taking biology. I was doing this fruit fly project. Oh, I still remember it to this day. We had to breed fruit flies and figure out the um, traits that our fruit flies had. Needless to say, it was a very complicated project. But at the time, we were learning also about a lot about basic biology, about human biology. And at the time, uh, the show ER, remember ER on
Hmm.
NBC, was just coming out with George Clooney and Juliana Margulies, and I was like, well, and it took place at a hospital in Chicago. I don't remember I think they called it Cook County Hospital, where there actually is a real Cook County Hospital. I rotated there when I was a medical student. And, it's a trauma center and it takes care of some of the sickest patients in all of Chicago. And I said, wow, like that's really cool that they're able to, save people's lives. There's also the movie uh, with what was the name of that? Indiana Jones. I'm blanking on his name. Harrison Ford.
Yeah.
He was a physician. What was it called? Gosh, now I'm gonna have to look this up. Harrison Ford played. What was the name of that movie? Jeez, I can't even remember. It was called. It's an old movie. It's a really old movie. It was called. Hold on, I gotta figure this out. It's crazy otherwise. Around the 90s. It was called The Fugitive.
Yeah. Oh, yeah, 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 yeah.
So
Oh my
in the
gosh, that was,
movie,
yes.
so in the movie, he hurts himself and he somehow breaks into a hospital and he's able to get medication and take care of himself. And I'm like, wow, he's got the knowledge to figure out that something is wrong with him. He knows how to fix it and he just takes care of it. And, you know, my parents always told me, if you figure out something that you enjoy doing and you're good at it, you'll have a great career. And they never really pushed me in any particular, field. Just find something that you're interested in, you want to do. And I thought to myself, medicine, I think I could have a talent in this. I think I could, do really well with this. And so all of high school, I knew I wanted to go to medical school. And then I went on to college. And even in college, I majored in finance. I knew I wanted to go to medical school. I made sure I had all my prerequisites. And eventually, and then I got in. I went to medical school. And then I did research for a few years. And then I went on to do my anesthesia residency and fellowship. And here I am practicing 10 years later.
And you studied at Harvard and you first were I mean, are you still an anesthesiologist? Would you?
Yeah, so I'm a classically trained anesthesiologist. Pain management is a subspecialty of anesthesia, just like we have pediatric anesthesia, cardiovascular anesthesia, or IC, or you can be an ICU doctor and be a trained anesthesiologist. Realistically, everything that we do is part of the perioperative experience. It's both getting the patients ready for surgery, uh, taking care of them through surgery, but then also taking care of them after surgery. And, the pain control is one of the most important parts of the perioperative experience because that's what people are most concerned about. Well, two things. They're concerned about waking up during the surgery. That's number one. That's usually the biggest thing. And then number two, how well is their pain going to be controlled afterwards? And surgeons today, they're very good at doing the surgery, but when it comes to the pain management, my field is really the experts of understanding the pharmacology of these drugs, about understanding how to titrate them, about using what's called multimodal analgesia, where we're using a variety of drugs to help control pain because there's no one singular pathway of pain that's transmitted through the body. There's multiple pathways. And the more drugs that you use in lower doses and that you can kind of knock out those pathways, the more likely you're going to control pain. Now, in today's world, we're really trying to minimize the amount of opioid medication. So we're trying to maximize the non-opioids like Tylenols and the anti-inflammatory drugs or the nerve pain medicines like gabapentin or Lyrica so that we can reduce the amount of opioids. On top of that, before surgery, a lot of times we're doing these nerve blocks, again, to help minimize their pain so that they don't have to use a lot of opioids.
Because when did it really? I mean, because I've had so many guests on my show. I even had a rabbi on last week, and he was talking about his journey. He had gotten hurt, and the doctor gave him opiates, and then he went doctor shopping, got all these
Mhm.
different opiates, and by the grace of God, like he literally had a God moment where like somebody had dropped off some heroin, and he was going to do heroin for the first time, but he didn't because he had this moment, and he threw it in the toilet and flushed it down. And so thank God he finally did detox and he's been sober for a while now. But so many people, and even young people that live here in Delray, you hear their stories and they're like, oh, I got hurt. The doctor gave me this and I went to this next level. How do you prevent that?
So usually the most common way people get introduced to an opioid medicine is just like you're saying. They have some type of injury, they fall, they hurt themselves, they were prescribed, a good amount of opioids, 30 tablets, 60 tablets, 90 tablets. And it was most frequently from like internists. Some of it was from, the orthopedic surgeons, but by and far, majority of it was the internists. And then also when people are having dental procedures, a little dental procedure. They give them like 60 tablets of Percocet. It's like, this is like, maybe 10, maybe 15 tablets type of situation. So with someone who has an addictive personality, even with just a few doses, they become instantly addicted to this type of stuff, whether it was how it made them feel or the euphoria from it. It's real. I mean, I can tell you from my own personal experience. I had my wisdom teeth pulled when I was like 15 or 16 years old, all four of them at the same time. I mean, it was pretty badly impacted. And I took a Vicodin. That was what my dentist gave me. And I remember taking one and waking up from a nap and saying, oh my God, the world feels perfect. I can understand how people can get addicted to this stuff. I mean, I had the know-how already at 15 years old, and I was like, I'm not taking that stuff anymore. That really messes with your head. And up until probably 5 or 10 years ago, the public didn't really know about this. They thought themselves, well, my doctor prescribed it, everything must be okay. There must be no issues with it. Up until when OxyContin first came out from Purdue Pharma, you had reps telling physicians, "Oh, your patient they can't get addicted to this stuff. This is a non-addicting type of medication." But internal documents were reflecting completely the opposite, and they weren't the only one. Purdue Pharma gets singled out because it was owned by one family, but the issues were with Johnson and Johnson, with Teva, with Mallinckrodt. I mean, all of these drug manufacturers were doing it, but physicians were kind of asleep at the wheel. They didn't really think things through, or they just, didn't think it would get this out of hand, and it did. It got really out of hand. And even Stanford was part of the issue. They were talking about pain was the fifth vital sign, and that it needed to be addressed as frequently as possible. Medicare and the government bought into that, and they even made there's these HCAP surveys that every hospital had to complete, or not. They didn't have to complete, but they had to give it to all their Medicare beneficiaries. And part of that survey was asking about how often and how well the hospital addressed their pain issues. And if their score was too low, they would lose reimbursement from the federal government. And what really should have been is not necessarily, how well, but the fact that it was addressed. It's impossible to take away 100% of anybody's pain at any given time, whether it's post-surgical or it's a chronic pain issue. And we need to be more realistic about it. You can't just ask, pain is a subjective experience. How you feel it, how I feel it, how my next patient's going to feel it. It's all different because not only is it a physical experience, there's the emotional component as well too. So everybody has different expectations from it, and this idea that again, American society is the instant gratification. You turn on the news at any given time, there's always these drug commercials that you got a problem, we got a solution for it. Chris Rock talks about it all the time, and in his stand-up comedy routines, and that's just where American mentality is. So I'm not surprised at all that we had this issue with opioid medications. The bad thing is now we have to walk it back, and how we're walking back is we've made obtaining these opioids extremely difficult. It is now causing people to go to the streets. You're going to have a rise in overdoses because people are taking street drugs. And like I mentioned before, these street drugs are being laced with fentanyl or any other type of synthetic opioid, whether it's fentanyl, sufentanil, carfentanil, which is, I think, used for veterinarian medicine. You're going to see a lot of it. And we're going to see a rise in the number of deaths. We're probably going to see a rise in HIV and hepatitis C. And probably at some point in the future, it will plateau out and then we will see it go back down. How long is that going to be? It could be a few years, could be 5 years, could be 10 years, who knows? But the real issue that no one wants to really talk about is that it's a mental health crisis. Most of these people that are getting addicted to these medicines, even though they're type A, it's like, what are they really self-medicating for? And I firmly believe that it is a mental health crisis that no one wants to address. You can take as many customs agents as you want and try to inspect every container that comes in this country. It's impossible. There is no way that you could ever search every car, every truck, every container, every passenger on every plane, every box that comes on an airplane, to try and find these illegal substances. But if you get rid of the demand, it doesn't matter how much you bring in, because then no one's going to want it. But right now, Medicare and the commercial payers, they don't really want to put any resources towards mental health. They don't want to, increase the compensation for mental health professionals, whether it's psychiatrists or psychologists or social workers. And that's really where we need to put our resources for. We don't have an unlimited budget in the United States, but we keep on spending money in areas that I don't think really make a whole lot of sense, that it's not really an investment in the American future. We're too busy trying to just put band-aids on things when really we should be proactive about things. We should say, all right, let's put more money towards mental health. Let's have, more counselors out there. I mean, look at all this bullying that we see online, the cyberbullying in the high schools, and you're seeing these kids committing suicide from this type of stuff. I mean, it's nonsense that we're seeing. And from my perspective, it looks really bad right now. But I think over time, I think we're going to see some improvement. I think so some of the people I've talked to who are in the mental health world, telehealth has really helped them. And I think that I think it's a bridge to the future. Having that, human interaction with people, I think is really important. I think the good old fashioned sitting on the couch and talking about your issues, I think that realistically, that's the best thing. Again, we're seeing this huge push of medications in mental health. And a lot of the studies, unless you have severe depression or severe whatever it might be, a lot of these medicines aren't really making a huge impact. And in fact, I think we might be doing more harm than good in terms of the medicine, treatment. Obviously, they do need it, but maybe we need to say, instead of putting you on this long-term, antidepressant, let's send you to a psychologist or a social worker. Let's get you in regular mental health counseling. And I bet you anything that is going to be more effective for people than just putting them on a pill. And then, then they, feel terrible from it. They have side effects from it. They don't like the connotation or the identification as a someone taking an antidepressant. Um, you know, there's a reason why all of these companies have their in-house social workers or psychologists now. It helps to improve the effectiveness of their employees. It tells you something. And we're just not doing that in an overall arching theme in all of society.
It's so crazy. Well, I've been sitting here taking notes as you're talking because I have so many things I want to go back
Sure.
and ask you. And one of the things that I swear is like the best sentence I heard that you said was like, we will never be able to take away 100% of your pain. Where did people ever think that was going to happen anyway? And when we get older, I mean, don't all of our bodies, especially if we've been even a little bit active, aren't we going to have some wear and tear? I mean, look at our cars. We have to replace our tires all the time. We got to change the oil. I mean, won't that happen to humans as well?
Yeah, I mean, it goes back to the old adage of the snake oil salesman. I mean, this is a marketing ploy of everything in the United States, that anything you can do will be perfect. And that's a fallacy. Everything is not black and white. Everything lives in the world of gray. I mean, think about anything you buy. You go get like you said, a new car, you get a new pair of shoes, or a new purse, or a wallet, or a belt. It doesn't last forever. I mean, how many things have you bought that said there's a lifetime guarantee on this product? A lifetime guarantee. You're buying, a coffee maker. How long does a coffee maker actually work? You're lucky you get 5, maybe 10 years out of it, and it breaks down. By the time it breaks down, the company you bought it from is out of
Out of
business. So
business.
that lifetime guarantee, they know they're not going to be around. So they'll be, oh, sure, we'll guarantee it, no problem. And even with our bodies, even though we do break down, people forget we have this amazing ability to partially regenerate our bodies. I mean, look at even the liver. You could take out part of someone's liver, and the rest of it doesn't regrow, it just gets larger, but it still functions at full capacity. You have an issue in any of your joints or any part of your body will try to regenerate itself, and the majority of times it does. When it gets to the point where it's beyond those are the patients that I see. And those are the patients that we try different types of interventions. And then even those patients, there are a certain subset of those patients that I can't get better, and then they have to go on to have surgery. But it's about being rational about this. When we have these things called professionals, we have these things called doctors, that my job is to look out for my patient's best interest and say, look, your pain just started a few weeks ago. Let's try something simple like, some anti-inflammatories, some physical therapy. Let's give it a few weeks or maybe a month and see how things go. And then if it doesn't get better, then we, rush to go, you know, do MRIs on them and, really see what the root cause is, and they kind of figure things out there. But in this culture, in this day and age, people want everything done right away. Because if it's not fixed right away, then I'm a bad doctor. If you look at a survey of patients, if a patient goes to a doctor and if they don't leave with a prescription, 75% of patients think that they're a bad doctor just because they didn't write them a prescription. And not every problem requires a prescription. Not every problem requires an injection by me. Sometimes we just have to like sit down and talk to patients. Sometimes there could be a psychological cause of people's pain, but you kind of have to read between the lines to see where it is. And you have to try conservative things first. In fact, with commercial insurance now, they won't even let you do aggressive things right away. First, you have to try the simple things, not because of what I did, but because of a lot of um, physicians that have overutilized the system. They've ordered too many tests, or now with the rise of what we call mid-levels of nurse practitioners and PAs, they have a much higher rate of ordering diagnostic tests from physicians than physicians. And so you got to kind of read between the lines. I'm not saying the first time you meet a patient, you automatically think it's a psychological cause. But if you've done x-rays and MRIs and physical therapy and medications and injections and people aren't getting any better, then you got to have to start to wonder, like, what's really the pain generator here? And it's not so easy to figure that out. First, by default, you're always assuming that there is a physical cause, because if you're not doing that, then you're really doing harm to your patient. Because what if it is something serious, you're missing it? What if it's a cancer or a fracture, and you just kind of rule that out? There are plenty of people who have psychological illness that have real physical causes of pain, but you can't discount the fact that they have a psychological condition to say, oh, it's just all in their head. No, that's completely wrong. You have to take it by case basis and really talk to your patient. You have to evaluate them. This is, that doctor patient relationship. Like, that's real. There has to be trust on both sides of the equation there. And in a healthcare system, when you have 5 minutes to sit and talk to your patient, how are you really developing that rapport with them? How are you really talking to them and learning about maybe the stress that's going on with their work, or stress that's going on between in their relationships? That's a real thing.
It is so real. And when we talk about mental health and I want to go back to one thing though. When you are diagnosing somebody, if they've already been a drug user, let's say, or an
Mhm.
alcoholic and they've been abusing alcohol, how long does it take to get a baseline to say, all right, this is what's wrong with you? Because if you're on heavy drugs, I mean, don't they stay in your system for a little while? So to get a baseline, it takes a little while.
Not necessarily. I think, like I said before, the first thing is you got to know your patient, and you got to see what really the cause of it is. Like I said before, in my book, there's always an organic cause until proven otherwise, because you never want to miss a cancer or a fracture and be negligent with your patient. On the other hand, if someone does have mental illness, that's not my first thing that I think about. There are plenty of my patients that I take care of that have mental health issues, but they have real organic cause. They have disc herniations, or they may have fractured their bone in their body. Um, and then conversely, there are patients who have no history of mental health, and I've done the complete workup on them. And there's nothing physically that I can find wrong with them. They have pain. I truly believe they feel physical pain, but the cause of it is not physical in nature. It's
Hmm.
it's in it's it's in their head. It's mental. I've had quite a few patients that had true physical low back pain, but upon X-rays and MRIs, and we've tried every injection, anything possible, they still continue to have pain. And they went to go see a psychologist. They went to go talk to somebody about it, and they found that it helped. They learned how to decompress. They learned how to deal with their stress, and their pain got better. Or I have a lot of patients who are self-aware, and they know that when their stress is worse, their pain gets worse. But part of their problem is also physical. They have degeneration through their body, but it always gets worse when they're stressed. And the question, is it because of their stress, or is it because they're not sleeping? Is it because their stress hormones are increased? It's probably all of those things. But it becomes a vicious cycle. And the sooner you can get someone's pain under control and or their stress, things seem to get better. Not 100%, but better and tolerable, basically.
Now, with a herniated disc, you mentioned those. Do they ever disappear entirely?
Yes, your body, there are, let's back up for a second. So you could MRI 100 people off the street, and some of them could have pain and some of them could not. And their MRIs could show you the same exact thing, a herniated disc. So just because you see a herniated disc doesn't mean that it always causes pain. That's one.
Hmm.
Number two, it also depends where the disc is herniated. In the neck, if there's a disc herniation, you'll feel pain in the neck and shooting down the arm. In thoracic spine, it'll be in the back. It'll kind of wrap around the chest area. If it's in the low back, it will shoot down the leg. Again, it's all following the patterns of where those nerves go. So even though it's herniated, your body is sending different cells there to try and resorb that disc material. It's trying to get that disc off of the nerve. Now, most of the times it's able to do itself. Sometimes it's beyond what it can do. And then again, they're coming to see me. We're trying an epidural steroid injection. And even with me, sometimes it's beyond what an injection can do. And then they have to go on to have surgery.
But does that ever fix it like automatically? Does surgery always work? Because I've heard from people that it doesn't
No,
always.
surgery is not 100%. And there are a certain subset of patients that have persistent pain. What that exact number is, I don't know. But the key is to reduce those things from happening is trying conservative things first. Having basically, algorithm is not, you know, widely accepted in medicine, but I think the better way would be a practice pattern. Again, you're trying simple things first. You're trying the physical therapy. You're trying the oral medication, not the opioids, but like anti-inflammatories or steroids. Then, maybe talking about a brace, whether it's a back brace or a joint type brace, working with the physical therapist, and then working with me, trying injections. And then I think if we go to a system where patients are diligent and they're doing that, if and when they need to go to have surgery, I think our outcomes for surgery will be dramatically better. On top of that, the surgical technique, we're going less invasive. The natural history of all of medicine is we do really, really, large surgeries at first, and then we realize over time sometimes doing less is better. The technology is getting better. Diagnostic imaging is getting better. You're going to see artificial intelligence come into this world, both on the diagnostic as well as the therapeutic side. And I think we're going to see dramatic improvement with the results because of that.
It's so crazy, this AI stuff, isn't it?
It is, but AI, or what used to be called machine learning, it's been around for a very long time. We're just at a point now where computing power is sufficient enough that it can actually work. And in medicine, we're going to have a lot of people are worried that AI is going to replace what they do. In my world, it's just going to be another tool that I use, whether it's an MRI or electronic medical record I'm using or a prescription pad or the equipment that we use. AI is going to help make better decisions. And it's all going to be for the benefit of the patient. It's not going to be completely controlled by the computer, but the computer is going to say, hey, this is what's going on in the patient. Why don't you try this? Statistically, this has got the best effectiveness. And I think that will help to improve a lot of these horror stories.
And our bodies are pretty smart within themselves, aren't they?
Yes. Yeah, our bodies are actually really smart, more than we realize. And I would say there is more that we don't know about the human body than what we actually know. Look at the Human Genome Project, which was completed almost a little over 20 years ago now. We can't even figure out how many genes are actually in our body. There was a huge discrepancy between the government project and the private one. We don't really know. And then on top of the genes, we don't even know why certain genes get expressed. And then look at all the issues we have in society. Like, look at mental health issues. I'm willing to wager in time we will find a genetic mutation in a lot of these people. Like, why do certain people have low serotonin syndrome, low serotonin levels? And that's probably what precipitates depression. And maybe we'll be able to figure it out one day. And I think once we can figure out where the mutation is, maybe our treatment of it, aside from psychological therapy, then we're talking about gene therapy, where we can actually change it. I mean, we've already seen that with sickle cell disease, where they're doing gene therapy to get rid of sickle cell, basically cure sickle cell patients. I mean, that is a huge leap forward.
My gosh. Well, and you think about it, when we were growing up, we had gym every day, right? We had to go to gym at school. I mean, I had gym every day. I'm a little older than you, but every day we had gym. And I don't remember, well, no one in my school like got Ritalin. I don't even think, maybe one person was like,
Mm-hmm.
oh, they're wearing a dunce cap like they had in the movies in the corner. And that was the one that was causing all the problems. But now today they're like wanting to diagnose every kid with ADHD, and there is no exercise. Like, where did exercise go?
Well, I think that I agree with you. Exercise is really important for every age group, but all these schools, they're running on a tighter and tighter budget. And when you have less money and your focus is on education because, schools are graded on, how kids are doing on these standardized tests. Well, then you're going to cut the things that are not essential. You're going to cut out fine arts. You're going to cut out, music. You're going to cut out gym. Um, And that's a problem. We need to really sit down and say, well, going to school is not just learning about academics. It's not just learning about math and reading, which are extremely important. Don't get me wrong. I'm a man of science, so I understand the utility of it. But there's also the health and nutrition aspect of life. And a lot of kids, unfortunately, aren't getting that at home. They're not being taught, well, you shouldn't have, sugar 5 times a day. Maybe, one little treat a day is what we need to limit it as, or, learning about the utility of fruits and vegetables, about needing to get out and exercise. These are important things. Look at the rise of diabetes amongst kids. I mean, it's untenable that you're seeing that. So, school is not just about learning about the academics. And as much as we always want mom and dad to be engaged in that educational process, but we don't live in utopia. We don't have families where, there is a mom and a dad, or mom and a dad that are present, or there's just a lot of components to it. And so, we try to provide as much as we possibly can in the school system, but, it's not as effective as learning that stuff at home. But you got to learn how to break the cycle somehow. We got to educate kids about how to maintain their bodies, about how it's important for them to run around and play. I mean, play is a really important part of kids' life, whether it's at recess or in gym, and they're learning about different sports, because you never know who the next superstar athlete is going to be because of being introduced that sport in gym. And health, the nutritional aspect, like you're just seeing these things being slowly eroded away from school, because there's just such an emphasis about keeping up with a certain metric, about a certain math score or a certain reading score. And there's so much more to that. It's not just the math and reading. It's about what kind of society are we really emboldening on our children. Is it just like, oh, you have to do great in math, and you don't have to worry about being nice to your fellow to the fellow students in your class? I mean, that's not good either. That's just going to be, this is why we're seeing what was it called, the Me Too, not Me Too, All About Me
Yeah.
type of um, uh, generation. And it's not just all about me, it's about society, it's about everything. Because right now you have 2/3 of Americans that are either overweight or obese. And with metabolic um, syndrome, which is high blood pressure, high cholesterol, and diabetes, it's dramatically increasing the cost of healthcare. And even though you and I keep ourselves healthy, if everybody else around us is not, and they're driving up the cost of healthcare, whether we like it or not, you and I are paying part of that premium. So it's affecting all of society. Look at the Medicare budget. I mean, if we could get, you know, all these Medicare recipients of a normal body weight, and they maintain that body weight their entire life. I'm not saying it would get rid of, the cancer or people who have genetic predisposition for, coronary artery disease, or, any of these neurological conditions that are probably genetic in nature as well too. But what about all the patients that are not? That it's just because they're overweight and they're fat, and they could have easily maintained a healthy lifestyle. It would reduce the Medicare budget. We wouldn't have to spend so much money. I mean, we wouldn't have to do R&D about, new types of GLP-1s, and all these new medicines that are great. Don't get me wrong; they're great medicines. I think they really are helping people, but a lot of people are taking it just because they're overweight, because they're 10 or 20 pounds overweight. Well, maybe you should just eat less and not spend $1,000 a month on Ozempic, or
Well, you brought up Ozempic. I just heard that they're going to start giving Ozempic to 6-year-olds.
it's possible. I mean, if it really does help and it improves their diabetes and it causes them to lose weight, it's not a terrible thing. But on the other hand, it should have never gotten to that point. There are plenty of kids who are type 1 insulin dependent diabetics. It's not anything that they did. They were just born that way. They probably have a genetic mutation where their islet cells just basically disappear. They even think that sometimes viruses can cause an autoimmune reaction and causes this destruction of islet cells. But if a kid is diabetic and they're because they're overweight, it should have never gotten to that point. There should have been much more intervention, both with that child as well as the family, about teaching them about health, nutrition, about activity. I mean, in the United States, we don't produce stuff anymore. Everybody sits at a computer 8 to 12 hours a day, and everyone needs to make a living. I'm not saying that people shouldn't, but we need to rethink how we live our lives, because if we are sitting in front of a computer 8 to 12 hours a day, we need to offset that by some type of activity in the day. People need to exercise like an hour a day, whether they get up and walk and they go strength training, they do some type of yoga, Pilates, or exercise, whatever they want to do, whatever makes you happy. It doesn't have to be just a one thing fits all type of thing, but you got to find that thing that you like doing that's physical, so you can burn off some energy, you can burn off some of that stress, and get us in the outdoors. These are all important aspects of life. Again, nobody wants to recognize these things. We just want to, there's a problem, we want to find a solution that's a drug so that we can profit off of it. Well, you can profit off of these things. Look at all these health clubs that exist. I mean, shoot, look at what the cost of membership. Some of them are doing really well. Look at some of these dietitians or these professional chefs that cook in a healthy lifestyle. I mean, they're making a lot of money. So I rather see people make money that way than just push more drugs on people that really aren't that effective.
So I've almost had you for an hour, and I know you have a hard stop because you probably have wonderful patients to see. So my last question is, if somebody's out there and they have pain, or their loved one, their child, or whatever has pain due to an injury or whatever it is, and they're worried and they go to the doctor, what are some questions you would have somebody ask their doctor? I mean, I feel so blessed that I found you. I mean, you're a recommendation to me, and I definitely, anybody who's out there, I'm definitely telling them in South Florida that they have to come see you, Dr. Kamerlink. But what do you tell people that don't live here in South Florida?
So I would say the first thing is always go see your primary care doctor, whether it's a pediatrician, your internist, and just be honest with them about what the issue is, how long it's been going on, because you never want to be in a situation that it's been going on longer than it probably should. Like, it's okay to experience pain a few weeks. Once you're at a month mark, you for sure should go see somebody about it. Something's not right, because what if it is something serious? You don't want to miss it. Whether you go see someone in 2 weeks or 4 weeks, if it is something very serious, that extra few weeks is really not going to change too much about the outcome. You're going to always think back in your head that it would have, but realistically, with modern medicine, it's not really going to change anything. So have that honest conversation with your primary. They will probably start you on the simple things, anti-inflammatories, maybe take an x-ray, maybe start you in physical therapy. And if after 2 weeks and it's not getting better, then I would ask them, I need to go see a specialist, whether it's a pain specialist like myself or an orthopedic surgeon. It really needs, at least if it's musculoskeletal. I mean, pain can also mean serious underlying issues. It could be a cardiac issue, it could be an internal organ issue. So it always needs to be kind of figured out. And worst case scenario, someone's coming to see me, and let's say it is a neurological issue. Let's say it is an ALS, or it's a Parkinson. We're going to order the diagnostic scans that are going to show, and then we're going to route you to the correct people, or vice versa. You see a neurologist and they say, oh, look, it's run-of-the-mill disc herniation. And I'm going to say, you need to go see a pain doctor, maybe try an injection, get yourself feeling better. But sometimes the fear of what it might be paralyzes people. They're scared to find out what it is. And statistically, it usually isn't a big deal. But you don't want to be one of those people that it is something serious, because that could be not such a great situation. But at least for me, I think it's better to know than to not know.
I agree with you 100%. Thank you so much for your time. It was
No
so great
problem.
having you on. I want to have you on again because I want to talk about this mental health thing even more. So I might have to send you an email and have you come back because there were definitely more questions on here, but I know you've got a hard stop. So I wanted to say thank you so much for coming on.
No
And if
problem.
you guys have any questions for Dr. Kamerlink, I'm going to have his email. Maybe I'll have something on there. We're going to talk about it when I'm stop recording so he doesn't get inundated, hopefully, with a bunch of emails. But I will have a link for you guys to maybe reach out to me and I'll see if he can take the email at this time or not. Because I know he has a busy life. He's got children of his own, a wife, everything going on himself too. But thank you so much for your time. And if you're out there and you have any questions, please, you can always reach me at elizabeth@elizabethchance.com. And thanks for being here. Thanks for listening. And I will be back in a couple days. And until then, everybody keep getting busy, living. So much. Bye, everybody. Take care.